Philemon. Good morning to you.
Good morning and good morning to your listeners.
Help me with your name. Is it Japan?
Yes, Philemon Japan.
Japan. Okay, like the OT regional minister. Yes, Japan. Okay, Philemon Japan. Okay, great. He's joined us for their own contribution to this whole issue. And I'm sure you've been monitoring and following the debates. Are we missing anything?
I think that the fundamentals must be assessed before we come into any form of conclusion. We might be overly emphasizing on the death that just occurred, which is a tragic incident. However, we need to look at the whole health system in a holistic manner. Take Accra. Greater Accra has a population of about 5 million, but we cannot boast of 1,000 bed capacity in our emergency. Add Rich Hospital emergency, Kolebu Hospital emergency, add UGMC emergency. I mean, all these 37 hospital emergency, let's count the beds. It means that we are unduly going to delay emergency care in these facilities. So there are fundamental issues that we need to tackle before we even go into the nitty-gritty of what goes on in the emergency sector. I have worked in the emergency unit before. I can tell you about 55% of our emergency nurses are complaining of low backache, spine pain, excuses here and there because of the pressure at the unit, which is another thing we need to look at. But currently, my emphasis is on whether we have the capacity to handle the emergencies in Greater Accra, looking at the looming numbers, the looming cases that are coming, and then the number of beds in the facility physically. I was listening to Prof. Bayo very well, but let's look at the fundamental issues.
I see. Very interesting. And when you're talking about capacity, I want you to help me break it down because there are a few things. Are you talking about infrastructure because you've mentioned beds? Are you talking about equipments? Are you talking about, because there's one of the things that have come up, the skills and even the professionalism of the people who are available. Which areas are we dealing with when it comes to capacity? Where are we lacking?
So all these things are capacities that are important. My emphasis is on the first issue about capacity. That is the total number of beds. Total number of beds in the facility that I've just mentioned. Before we go into skill, before we go into infrastructure, how many of these facilities, because there should also be inter-facility coordination where when you come to Rich Hospital and the place is packed, the patient shouldn't be combing around and looking for another hospital. Rich Hospital should be able to, in the interim, receive the patient once triaging and getting some emergency services to that person. Coordinate with other facilities like maybe UGMC or Kolebu to see if they have capacity, and then they can tell the ambulance team to refer or to take the patient to that place. But if Rich is receiving that patient, is Rich in the capacity to handle the patient at that time? Do they have the staff? Do they have emergency nurses to triage? Do they have the doctors readily available to assess and treat some emergencies? Do they even have the facility? That's what I'm saying, that most of our nurses and midwives in the emergency area, the emergency nurses and the emergency staff are complaining of back because they will have to nurse and then attend to or try some people in wheelchairs, in stretchers, some on the floor, depending on how packed the facilities are. We need to look at this holistically.
Would the law help?
The law is very proactive. The laws were made for us to be able to guide our dealings and our working. If you are going to apply the law strictly, it's not going to help. If you have not provided enough facilities and enough beds in the emergency unit, and you you are saying that the place is full, the staff tells you that the place is full, you cannot accommodate any more staff. You want to apply the law for maybe negligence of care or failure to render emergency care. How will you juxtapose that with your provision of those facilities at the unit for the individual to work? If you are going to go by the law, a lot of the patients may be turned away, or a lot of the facilities will come to a standstill because there are a lot of facilities that improvise to be able to render emergency care. They improvise to be able to render health services to patients. So if we apply the law blindly, we are going to be on the lookout. We need to be very balanced in our perspective on how to apply the law.
Because the speaker is also proposing an emergency care law. First of all, what do you think of that? Secondly, what do you think that law should contain if it is to help?
We need a broader stakeholder engagement. Let's call people at the emergency unit. As an association, we have GRNMA has specialized societies under us, and we have all the emergency nurses as a specialized society under us. We engaged them in our next meeting 2 days ago, and they were proposing some of the possible solutions, some of the challenges that they are facing in those areas, so that it helps us with decision making and then policy direction. We need to be holistic about this before we come up with any law, so that we don't shoot ourselves in the foot. Okay, so we have passed the law that when patients come to the emergency, they must be admitted at all costs, which is very important. Now we have over-admitted people. Some are lying on the floor. The same patients can sue you for negligence of duty because you have packed the emergency. Some are on the floor. They are not getting the needed care, and then they are going to die as a result of lack of those facilities and the clients, the specialized services that they need in that emergency unit, or the staff who are supposed to render the quality care. Most of our emergencies are fewer. They have staff, but the staff are fewer than what is required. How have we been able to address those challenges? So I want us to be holistic before we pass any policy or before we drift into law.
And I'm because I heard is the word triage, the nurses who are usually responsible for this emergency. When you spoke to them, what were the proposals they made to you? Because you were talking about the basics beyond provision of the bed. What else did they say were lacking?
There are phenomenal provisions that we can espouse. I'm sure we cannot exhaust that on this call. We are not taking a one-sided view, not only what they have seen. We are also doing an analysis of the various emergency departments, looking at the management setup. But the core of it is the staff, the number of emergency nurses, doctors at the facility. That's key. The second is the bed, physically bed or the space, emergency space. The third is provision of equipment. We need enough resources at the emergency unit. You need ventilators. You need to resource the place well, because if somebody even comes in a certain state and you don't have those emergency equipment available to readily attend to the individual, no matter the number of staff that are there, no matter the beds that you have there, you eventually lose the patient because you don't have a ventilator, you don't have oxygen, continuous oxygen supply to the place, you don't have oximeters, you don't have intubation kits, you don't have different things that we use to be able to ameliorate the care. The other thing that we saw was the worrying trend was where patients or individuals in this country think that the delays at the health facilities is unbearable, so they wait for their issues to turn to an emergency before coming to the hospital. So if you go to the hospital around 10 p.m., 9, 10 p.m., you see a chunk of people coming in. Those people could have been seen at the OPDs during the day, but they feel the OPDs are delaying. They don't want to waste time in the queue. They have to go to work. Some also wait till their issues are compounded. So when they come to the emergency, it puts a huge overload on the staff, and it tends to affect those who need critical care. These are some of the challenges that were mentioned.
Okay, so a few things first of all. Do you admit in some cases the problem is the healthcare professional?
You have to give me a case scenario because
So an MP told a story yesterday where he said he was taken to the hospital, an emergency situation. Initially, what he was told was that there is no bed. In fact, they insisted that there was no bed to take care of him. But when his wife said, he is a member of parliament, they found a bed. They were able to find a way of taking care of them. There are people who tell stories about having taken people who they feel have emergency issues to hospitals, and nobody even pays attention to them. Nobody would even come and check their blood pressure or whatever it is. Nobody would check to see, oh, is this a serious issue? It is nobody. They see nothing, and people are not bothered at all. Do you admit that that is also the problem? It's also part of the problem and needs to be dealt with.
Okay, so that may not be entirely true. Let me. There are two ways to it. I have worked. I said initially.
When you are saying that may not be entirely true, are you saying that these people who tell the story are lying?
No. That's why I'm saying that may not be entirely the case, because if you are an MP and they said there's no bed, there's no bed. The fact that maybe you know somebody and then some arrangement of a sort. So probably a doctor may have to come and review the patient, look for somebody who is not in a very critical situation, to move that person to the ward so that they can admit you there. That intercession or that intervention to get you a bed doesn't change the fact that there was no bed. That's why I'm trying to balance the approach. The MP is not lying. The individual who told you he went to the emergency, it had to take some other efforts through maybe a health worker he knew, a doctor he knew, to get him a bed, may be telling the truth. But also the truth is that probably some arrangement was made to move somebody to be able to create the bed for that person. And that is what I'm saying, that the person who said there was no bed may not be lying. There was no bed, but some arrangement was made. So my issue is that why can't we also do the same thing for ordinary Ghanaians? Not necessarily an MP. I was in the emergency department when they brought a rich man to the place. He had a diabetic coma. He was rushed there, and then there was no bed. We had to nurse, because it was an emergency. We had to nurse the person on a stretcher and give him emergency care drug to be able to revive the person. When the person got up, or when he became conscious, his people were questioning us why we put a big man like that on a stretcher to see. They were beginning to question us at that time. It's some years back, and unfortunately, I mean, we couldn't say much to them. The trend is not the same when it comes to the bigger hospitals like Kolebu, and then how do you call it, UGMC, Rich Hospital, and all that. They maybe have worst case scenario, and sometimes people make arrangements to be able to move some other critical patients to be able to create a space. That does not necessarily mean that if you don't know anybody, you go to the hospital, you are going to die. I'm saying that let's tackle the issue holistically. Let's look at physical provision of the bed. I told you we can boast of 1,000 bed capacity of emergency in Greater Accra, with about 5 million people. This calls for an immediate expansion, looking at emergency scopes. So that may be the situation. It's not that somebody is telling a lie.
You have also not addressed the issue of conduct of some health professionals.
In terms of conduct, what do you stick to?
I'm saying that in some cases, some of the stories that have been told and told to us this morning is that some of your colleagues just do not bother. They won't even attend to you.
I cannot go brief for all my colleagues, but having worked in these facilities and I know how worrying it is, I know as much as possible, all nurses and midwives, all the healthcare professionals at the emergency unit are there to save lives. I happen to be part of a committee that was looking at emergency preparedness when we were doing peer review, and we stimulate emergency. Conduct was one of the things. Your receptivity was one of the things. Your ability to even create space for such situation was one of the things. So for conduct, I know that to a large extent, most nurses and midwives are readily available to give you the care you need, to give you the service you need. But sometimes they get overwhelmed. They get swallowed up with the work. They get swallowed up with the frustration. And some of these things sometimes share those reactions. Imagine people come to the hospital emergency with a motorbike accident. When they rush the person in, whilst you are attending to the person, they bring another crop of maybe somebody who has collapsed. The person who has collapsed may need an urgent care because maybe he's losing vital organs if you don't put in a certain intervention. So you might have given some preliminary treatment or care to the first person, and then you are going to attend to the second person. The relatives of the victim begin to now question you, the staff who knows your work and you are doing it. They try to even dictate how you should do the work. And a little attention that you couldn't maybe offer to that person to even explain the incident or the ramification of the person's condition is what is misconstrued and carried that the staff has a bad attitude. So we need to look at it holistically. I think there are some few people who naturally don't have a good attitude or good how do you call it, interpersonal relationship that may have led among the staff. We call them to order every time and when it is reported to us. When we have staff facility managers, we have unit heads. Once you are reported, you are called out and you are given sanctions. But before we call them out, we give them chances. Let's address the issue.
Well, Philemon, thank you. Thank you very much for speaking to us.
Thank you for having me.
Philemon Japon is National Deputy Public Relations Officer, Ghana Registered Nurses and Midwives Association. He says there are basic problems that need to be dealt with, first of all. And I recall what Prof said. Professor Bayu said, in some cases, even emergency is an afterthought. That when we are building facilities, we do not incorporate into the construction, the possibility of emergencies. So what we are doing is an afterthought. So we finish before we start thinking, oh, there'll be emergency cases. So then maybe you are now trying to convert something that was already there into an emergency department. You are that maybe the building too might not make room for in case there are emergencies. If I put somebody in a wheelchair and I'm pushing the person from the gate into the facility, how is the facility built in a manner that it is easier for me to just use push the person in the wheelchair so because there are some facilities where you have to use steps to get up. So imagine pushing somebody up the stairs in wheelchair. So there are many things. Perhaps he has a very good point. The extent to which we think about emergencies in building hospitals. And Philemon is also saying the same, that in some cases, in the case of the MP, when you hear MP, you try to find room. But he says that it's just possible that there were no beds. But because he said MP, the people do not want problem. They can find, maybe the patient may not be still in serious critical condition, so they can be able to adjust him a little and take care of the MP so that You don't wake up in the morning and have Senna calling them and finding out what has happened. Good morning to Estella Graciela Lawrence Brown says the doctors should be sensitive to the needs of the patients. Neil Ate is joining us. Near Yemos, 5 million people do not need an emergency at a time. It's a, is it? No, it's a Japan. It's too defensive in regards to the emergency situations at the hospital. Urgency to care is the problem. And I was asking him that. He says he cannot hold brief for everybody, for all his colleagues. In cases where it has been reported to the supervisors, they've dealt with that, where you find maybe a healthcare professional. I don't want to say a nurse because people have gone after nurses. A healthcare professional, maybe the person is not even a nurse, so you say the person is a nurse. A healthcare professional with a very bad attitude, who has not shown any care to somebody in an emergency situation. If you find someone like that, they said in most cases, they are able to cater to ensure that they reprimand the person. But he says there are some nurses with very bad conduct and bad attitude. He admits that. So we'll just have, I think, one last small conversation.